Assalamualaikum and good morning to everybody, and good morning to UMMC. We are at breakfast at UMHealth, episode 43. Okay, and for the first speaker, which is Dr. Raymond Lim from Department of Obstetrics and Gynaecology, he's going to talk about COVID vaccination in pregnant women. We know that COVID infection in pregnant women can be quite severe, and twice the likelihood of these women who get infected can be, be very severe and admitted to ICU, requiring ventilation and associated with premature deliveries. And vaccination is one of the, prevention methods. And Dr. Raymond is the main person in our department who has made the success for vaccination in pregnant women in our hospital. So without further delay, I would like to invite Dr. Raymond Lim, who's going to speak about COVID vaccination in pregnant women. So pass over to you, Raymond.
Thank you, Prof. And good morning, everyone. So I am just going to share my screen first. Okay, can everyone see my screen? All right.
Yes, we can. Raymond, proceed.
So the title of my talk today is about COVID vaccination in pregnant women. As Professor Sofiah has alluded earlier on about this COVID vaccination, COVID infection. It first hit us in March 2020, to be exact. Even though it was first found in Wuhan, China, at the end of December 2019, it didn't actually reach our shore until at least March 2020, mid-March. So just going to do a bit of introduction regarding COVID-19 infection. It is a contagious disease that causes SARS, or severe acute respiratory syndrome, and is caused by a type of coronavirus, which we believe is transmission over from a zoology to the human, rather than originating from the human infection. And as I said earlier on, the first known cases was found in Wuhan, China in December 2019. And since at least until middle of 2020, when the WHO declared this as a pandemic, it has been there since then until now. It is coming up to 20 months, if I'm not mistaken, that is causing us this problem. And it is, as we all know, it was originally in the alpha beta variant and the gamma variant. It was through droplets and fomite and also body fluid. But as we know, with the latest variant, Delta variant, it does come within the atmosphere as well, within close proximity. As we all know, the common symptoms are always there, and we are always on the lookout, everyone. I hope and I believe, especially me as well, if I see my patient in the antenatal clinic and or the gynecology clinic, if they have any URTI symptoms, I would really treat them with caution, because the likelihood is quite high that they may have COVID. Not to say they won't, or they will definitely have. Obviously, if they need admission, as per our SOP in the ONG department, we would want to do a RTK at least to make sure, or a rapid antigen test kit, to make sure that they do not have COVID. The most common symptoms we should always be on the lookout for would be fever, coughing, loss of taste and smell. Tiredness can be obviously very ambiguous, especially in the pregnant women population that tend to get tired more easily, especially in the mid-trimester and late third trimester. And the last common one, like I said earlier on, was sore throat, myalgia, arthralgia, diarrhea, okay, irritated eye. Okay. Risk of COVID-19 pregnancy, as Professor Sofiah said earlier on, pregnant women with COVID-19, they tend to have a higher risk complication compared to the non-pregnant women population, mainly because their immune systems are compromised when they are pregnant. So as I say, look out here, there's an increased chance of at least up to 5 times. This is based on epidemiology studies done in the UK. And the paper is published in BMJ, a British medical journal. They did studies and they found that pregnant women are more likely by up to 5 times to be admitted to hospital and 2 to 3 times admitted to intensive care, which is in accordance with our UM or PPUM statement as well, that it is about 2 times or 1.98 times more likely to be admitted to intensive care unit and up to 3 times more likely to needing breathing support or invasive ventilation. Okay, and this is particularly of a concerning feature, especially in the late 2nd and 3rd trimester as the pregnancies get bigger and you get a gravid uterus. As we all know, physiologically with a gravid uterus, the uterus would push the diaphragm, hemi-diaphragm further up, and that would already, even without COVID vaccine, without COVID infection, they are, in terms of respiratory wise, a fair bit compromised. All right, and not only that, and as I said, because of what I alluded early on about the complication that can happen to the pregnant woman, obviously it will have a knock-on effect on their babies that are carrying as well. And mainly that it is an increased risk of up to 1.5 times more likely to be born prematurely and 3 times more likely to be admitted to the NICU. Okay. They are, as per what I said earlier on about the BMJ studies paper, some pregnant women are more likely to have severe COVID illness from COVID-19 compared to other pregnant women. Mainly those they found were the more aging pregnant women, like those above 35 years old, or overweight and obese with a BMI above 30, or if they have, as we all know, even in the elderly population in the early days of the COVID-19 virus infection, those with comorbidity like hypertension and type 1, type 2 diabetes, they are more likely to get COVID and succumb to it. This is also true in the pregnant women as well. So, as we all know, I think if I'm not mistaken, it was until September 2020 when the COVID vaccine was first rolled out in the United States, followed by United Kingdom, before it reached our shore in the end of March 2021. So in that COVID vaccination program in the States and also UK, they do recruit pregnant women as well. And in fact, in the United States, they have a real-time data for pregnant women. For those pregnant women who get vaccinated, there is a program called VSAFE, vaccination, which they can register via the mobile app. And up to now, I think that there's about 169,000. The last I checked on the 25th of October, that was the most updated one. 169,000 pregnant women of all gestation who has had the vaccination, and the vaccination we're talking about is the mRNA one, which is about Pfizer or the Moderna. Okay. And we all know this COVID vaccination would help to at least prevent us from getting the COVID-19 virus infection. Well, the efficacy is up to 93% from the Pfizer, and for those who they found in the studies that also got contracted COVID-19 virus infection despite being fully vaccinated, the chances of them from progressing to type 3, 4, 5 or stage 3, 4, 5 of COVID-19 virus infection is least likely, because the vaccine does provide some protection. And my talk today is mainly going to be based on the mRNA vaccine and community, which is being used by us here in Malaysia. Okay, and as you can see from my slides here, it says I mentioned earlier on about the potential effect of the COVID-19 virus infection to the pregnant women and also the baby. And as with any other health system in the world, everyone is actually promoting vaccination for the pregnant women to prevent or reduce the admission of the pregnant women to the hospitals, because there are a lot of potential effects that can come on at once the patient is being admitted to hospital. As you can see early on, the women are carrying themselves and also the baby. So if anything were to happen to the pregnant women, also the baby is most likely to be affected, and this can affect our health system as well. Okay. Other vaccination that is available in the Malaysia just now would include Sinovac and Sinopharm, AstraZeneca, which has been here in the early 2021 as well. All those are the different, they use the traditional technology, which is they use the viral vector as to deliver the vaccine to the human body. As you all may know in the media as well, AstraZeneca hasn't been well studied in pregnant women because it was found to have a rare risk of people who are aged below 60 to contract thrombosis with thrombocytopenia symptoms. And in a very rare situation, it may cause brain cerebral vascular thrombosis and followed by the death of the patient. And for that reason, that is why pregnant women is ill-advised against having AstraZeneca vaccination. Okay, particularly when pregnant women, their blood tend to be have a more thrombotic feature. So the next question I think the public would like to ask is the COVID-19 virus, is the COVID-19 vaccination safe and effective for pregnant women and babies? And as I said earlier on about this robust real-world data from United States, which is based on the VSAF one, about hundreds, it was, like I mentioned, the updated one on the 25th of October, about 169,000 pregnant women has been vaccinated, mainly with mRNA vaccines, like the Pfizer one, which we are using, or Comirnaty, that's the brand, the brand name, or the Moderna one. There hasn't raised any safety concern of such. Okay, and on that basis, also in the UK, there have been some studies, as I checked in the RCOG, or Royal College of Obstetrics and Gynaecology website. They have done some studies as well in the Scotland and the England. And there is a joint committee on vaccination and immunization called JCVI. They also advise that pregnant women be given the mRNA vaccine. Okay. And as we all know, from the delivery of the COVID mRNA vaccine, the mRNA protein would disappear from the body within a few days of administration. And for that reason, we believe that it doesn't cause any harm to the pregnant woman or developing babies. In fact, there were some studies done on animals to look at the effect on the pregnancy. And I mean, these are based on the mRNA vaccine, and they haven't found any concrete evidence that it can cause harm to the pregnancy or the fertility wise. Okay. And as we all know, the benefit of vaccination would include reduction in severe disease to the pregnant woman, like I said earlier on, and also reduce the risk of stillbirth and prematurity to the baby. And not only that, it also reduces the transmission to vulnerable household members. As we all know, some people would be living with their parents, older parents. Those are the most susceptible ones that we have to look out for as well, or watch for as well. And like I said earlier on, there's very limited data on the safety of the viral vector vaccine, just such as like AstraZeneca. Obviously, the Sinovac one, it was only published in the New England Journal, but that wasn't based purely on pregnant women. And my talk this morning is purely based on pregnant women, so I cannot say for sure. But so far, from our studies or administration of Sinovac here in Malaysia, it hasn't caused much problem to the pregnant women, as we all know. So what is the potential impact? If the next question everyone will ask is, what is the potential impact of COVID-19 vaccination on babies born to women who have been vaccinated in pregnancy? As we all know so far, on short-term effect, which I mean is now or in a year or two, or we're only coming up to 1 year after vaccination of mRNA vaccines, there haven't been any non-danger to the women, to the babies delivered by the women who have had the vaccines. Okay. And in fact, it's the IgG, which is a long-term immunoglobulin, the memory cell, is also found in the baby. Whether this have any protective effect on the baby and prevent them from having COVID-19 virus infection, we do not know that yet, because there hasn't been any studies done to study what are the potential impact of the vaccine and I mean benefits rather than any damage to the to the babies whose mother has had the vaccine. Okay. And one thing for sure is we know so far, and as I said earlier on from the studies of the VSafe and also those in the United Kingdom, there haven't been any increase in cases of miscarriage or stillbirth or preterm birth for those women who have had vaccine. Okay. And that was based on a research from across 6 studies in 4 countries that involved 40,000 pregnant women. So as I said earlier on, it doesn't increase the risk, not only to the women, but also to the baby. There's no any increased risk of, it's more for gestational age baby or those with congenital anomaly. And that was confirming the earlier on slides that I showed that pregnant women, I mean, some animal studies done with using the mRNA vaccine, it hasn't found any damage to the pregnancy of the animals that were studied or cause a fertility problem. Okay. The next question, women, and I think a lot of women in the early days when we started recruiting patients, pregnant women for vaccine, they are hesitant mainly because they thought it might have an effect like cause miscarriage or stillbirth. And I just want to confirm, to make this statement, this is based on MRSA, which is the Medicine and Healthcare Products Regulatory Agency of the UK, which is equivalent to our Malaysia's MPRA, which is the one that approved vaccination. They have been collecting data and there hasn't shown any increased risk of miscarriage or stillbirth amongst women, pregnant women who have had the COVID-19 vaccine. Next things I would like to say, side effects from the COVID-19, which is the most common one people would experience, and the pregnant women's experience are not any different from the non-pregnant people like us. The most common one would be the pain at injection site, tiredness or headache or myalgia, diarrhea, fever, or arthralgia. Okay, and in such cases, we recommend that pregnant women just take paracetamol or Panadol or acetaminophen, which is the generic name for the side effects that I mentioned above. Okay. So when is the best time to have the COVID-19 vaccine? As per our MOH guideline on COVID-19 vaccination for pregnant women and breastfeeding, the right time to have it would be 12 weeks and above. Okay, I think there's still some confusion here, because when I go over to Menara Selatan 13th floor, which is our vaccination center, I do have session there where I have to approve assess and approve certain people who came up because they have been sent over from the clinic Kesihatan because they are told that they cannot have the vaccine anytime sooner or later. Because I think in the general public per se, and this is also true in Fly FM. I'm not going to point exactly, but I listen to Fly FM a lot. There's still advertisement about asking people, pregnant women, to have the vaccine between 14 to 33 weeks. This is particularly not true. This is true in the early days of our vaccination, but our MOH or Ministry of Health has changed the guideline to include to say the pregnant women can start having the vaccine from 12 weeks of gestation above and until delivery and breastfeeding. So there is no limit up from 12 weeks and above. But I have made some research into when it would be safe to have COVID-19 vaccine. Obviously, it is not a strong concrete data because it is based on a small number of women who were not aware that they were pregnant when they had this COVID-19 COVID-19 vaccine or mRNA vaccine. And subsequent to that, the follow-up doesn't show any impact, like I said, any congenital abnormality or any risk to the pregnant woman. In fact, if you were to look up on the RANSCOG, which is Royal Australia and New Zealand College of Obstetrics and Gynaecology, RCOG, which is Royal College of Obstetrics and Gynaecology of the UK, and also the American College of Obstetrics and Gynaecology. So these three are quite reputable colleges in the obstetrics and gynecology in our real world. They conclude that the vaccine can be given at any time of pregnancy. You do not have to wait till 12 weeks. Okay, as we all know, in the early days of Delta variant, and also here just until recently, before this, the Delta variant COVID-19 virus infection is very rampant and is causing a lot of mortality or death, and that is the reason why we shouldn't be waiting until 12 weeks, in my opinion. And this is what the RCOG, RANSCOG, and ACOG say previously. It can be given at any time of the pregnancy. Obviously, Malaysia government has been on the safe side, and which I cannot fault them for it. They recommend mainly 12 weeks is for the theory behind it is because by then the organogenesis or the formation of the organs in the baby or the pregnant or the embryo or the pregnancy would be complete, and it would have least side effect on the pregnancy. Okay. And I'm just going to go through a bit about this MOH guideline, which was updated on the 10th of August. In the pre-pregnancy, okay, despite what I said earlier on, this is what the MOH guideline suggests to couples or the women. Before they get pregnant, they are advised to complete their vaccination first. And it does say that the vaccine does not cause any problem to the infertility or sexual dysfunction. And once you're fully vaccinated, there shouldn't be any delay in conception. As for the ART or assisted reproductive treatment, which would include intrauterine insemination, medical ovulation with clomiphene, or with IVF, which is the most common ART done in this country and also the rest of the world. Couples are encouraged to complete their vaccination first before they embark on the ART. And this is where there is a in the field of fertility, there is a separate point of view, split point of view between the Americans and the European. The European Reproductive Health Society is of opinion, which is I think what Malaysia's Ministry of Health is following, is that they should complete their vaccination first before they embark on assisted reproductive treatment. Whereas the Americans are of the belief, or the ASRM, American Society of Reproductive Medicine, they believe that it can be given, like what I said earlier on, and whether you're conceiving or not. As what the RCOG says, whereas in the RCOG website, if you check it out, they said it is advisable for them to complete their vaccination first before they embark on controlled ovulation stimulation. Okay, because as we all know, in IVF field, where we involve giving injections to enlarge the follicles, there are potential some of the symptoms that you can have, which this vaccine may make it worse. That's why, just for that reason, they advise in the Royal College of Obstetrics and Gynaecology, they advise that women should complete their vaccine first, okay, just to make them feel, safer and better. During pregnancy, as I said earlier on about RCOG and RANSCOG, it does, and this is what I said earlier on in the earlier my statement, I said it can be given anytime, whereas in Malaysia, we give it from 12 weeks and above. Okay. The another thing is you do not have to delay, because sometimes I do get a call from midwife asking me, so they are around 39 weeks, can we still give the first dose of vaccine? And I said yes, because like I said early on in the previous guideline by Malaysian MOH, it says it only can be given between 14 to 33 weeks, but that has changed now. So you can give it even towards the end of the pregnancy, the first dose, and then the patient can continue to have the second dose post-delivery. And during breastfeeding, they said there shouldn't be any interval. In fact, it is known that the breast milk do contain IgA of the vaccine, which the baby will receive as well when they get the milk from the mother. And obviously, like I said, there's not been any data to suggest whether is this protective enough or to prevent the baby less likely to get the COVID-19 infection. Okay, perhaps that is something we can do in the neonatology side, because we do have pregnant women who contracted COVID-19 virus infection. Subsequent to that, they had cesarean section or delivery via vaginal delivery as well. And obviously, they are still allowed to breastfeeding. But I think there's something maybe we can look into the studies in this small cohort of babies born or delivered by the women who had COVID-19 virus infection and they're breastfeeding, whether there's any danger or any risk of the baby getting the infection from the mother. Bearing in mind, regarding breastfeeding, we did ask the mother, we always advise the mother to wear masks when they are breastfeeding to prevent the transmission to the baby. And as for the adolescents, this is the bit where we just started vaccinating the pregnant women, the teenagers from 12 years old to 18 years old. We just started 4 weeks ago, if I'm not mistaken. This is the part where we have to discuss with the parents, because as we all know, there have been cases of myocarditis and pericarditis to those adolescents who are below 18 years old. It has been picked up. This is per se for the mRNA vaccine of Pfizer. And obviously, we have to weigh the risk of getting this versus the benefit of the women or the girls who are pregnant between the age of 12 to 17 of getting the vaccine. And obviously, we would encourage that the parents or the guardians are involved in the conversation, and an informed consent is taken from them to allow the adolescent to have the vaccine. Okay. Another thing is about the vaccine. The women can have the vaccine together with other vaccine like tetanus and pertussis, all right, together, so they can have it concurrently. There is no need to delay one or the other. I'm coming to the end of my talk now, and about this booster dose, which is just being rolled out 3 weeks ago now. There's always been talk about whether pregnant women should get it. As we all know, the pregnant women normally get it within, they haven't, by the time they deliver, they're not up to the 6 months yet. So this is the newest guideline from the MOH for those pregnant, for those people who can get a booster dose are those with a frontliner, social care worker, or those between 16 to 49 with underlying comorbidity, or adult, all the adult in the household or with an immunosuppressed individual. And as we all know, adult above 60 and those living in residential care homes for the older adults. And for pregnant women who have who take for all this category, then they can have the booster dose. Okay. I think I'm coming to the end, just right in time of my talk now. If I got any question that you would like me to answer.
Okay, thank you, Dr. Raymond, for that, about vaccination and COVID infection in pregnancy. You have a few questions here, but I'm just probably only one question is allowed. Probably we are almost 8:30. So this is a question from Yu Quen Chan. Okay, I'm just going to read it for you. Vaccination against COVID-19 protects against severe disease, which is category 3, 4, and 5.
Yeah.
But there is minimal data, almost no studies. It says here before, when the vaccine was, before it was launched, to support that it prevents a vaccinated person from getting the disease. All right. So he says, I'm sure this applies to the pregnant patients as well. So what's your comments, please?
I think I don't quite agree with that statements of like there's no study that was based on the mRNA studies. As we all know, the Pfizer one or the Comirnaty one, when there says the efficacy of 93%, that is based on the chance of 93% you are unlikely to get COVID-19 virus infection and a 7% chance that you're going to contract it. But what they found in the studies, that studies was even those 7% who contracted the infection, they only experienced stage 1 or 2, not above 3 or 5, and that was based on that. And this is what we translated over for the pregnant women, and it was also found, like I say, in the V-Safe studies in the States, that it is what is the vaccine 93% efficacy is. And obviously we know the latest studies done in the Israel and also smaller studies in the States, is 6 months, the antibody wane off after 6 months, and that's when the efficacy dropped down to 58%. And that is the reason why they start giving people booster dose. Obviously, for pregnant women, like I said earlier on, most of them will not qualify for booster dose yet because they all get it within the 6-month period. By the time they have the second dose, and then following up to the 6 months, they would have delivered the baby, most of them. And that's why there hasn't been much study yet. The only pregnant women that would qualify would be for the booster dose would be those that tick the boxes I mentioned earlier on, the frontliners, or those who are living in the elder people who are older population.
Okay, so that actually answers, isn't it? It does protect and prevent to some degree, isn't it? Okay,
Yes.
because pregnant woman is just like any other adults. Okay, so the few other questions, they want links to the data. I think that was in your last slide. Okay, all the references, you can refer to that. And it says here, small study on pregnant breastfeeding mother, but it's quite significant. That's what we have as a prevention. I think probably we can end and hand over to the second presenter. And thank you very much, Dr. Raymond Lim, for that excellent presentation.
Thank you.
Any other question they can ask to you directly, I think. Okay, and I'll pass over to Dr. Terence for the second presentation. Thank you, everyone.
Brilliant. Okay, hi. So for the second half of today's presentation, we're very much moving from trying to tackle one public health problem to another public health problem. This one being fragility fractures due to osteoporosis. So joining me today are colleagues, Drs. Khor, Dr. Jeyakantha, and Dr. Kumar, representing different departments within the hospital, who've got a very shared concern for all things osteoporosis and fractures. So for this particular session, I'll just kick it off by a short presentation setting the scene and highlighting why this is a problem before I bring my colleagues in, where we'll certainly discuss this topic in a little bit more detail. So osteoporosis is a highly prevalent problem. With time, bones become more fragile, more porous, and the worry is after very little trauma, whether that be a trip or a very strong sneeze, the bone would crack, the bone would break, the bone would fracture. A few weeks ago, we had World Osteoporosis Day, which was on October 20th, and the International Osteoporosis Foundation reminded us again about the enormous burden osteoporosis and fracture has on us globally. So 1 in 3 women and 1 in 5 men over the age of 50 will sustain an osteoporotic fracture in their lifetime. Worldwide, 8.9 million fractures occur annually, which means by the time I finish this sentence, someone would have broken another bone somewhere in this part of the world. Now, and it becomes a big problem because as we get older, we are starting to see a lot more fractures occurring. Now, this is data from the Swedish Fracture Registry, and what you can see from this graph is how fracture incidence increases and increases exponentially as one ages. And you can very much repeat this study in UK, US, Australia, Korea, New Zealand, and you will get a very consistent picture where fracture incidence increases and increases in this manner towards the older age group. Now, we don't have much fracture epidemiology from Malaysia, and certainly the most robust one today took place some time ago, and this was published by Lee and Khor in 2007. So they didn't look at all fractures, but chose to focus on hip fractures, because that was much easier to source the data from. And again, you see a fairly similar picture where fracture incidence goes up, and again, I repeat the word goes up exponentially towards the older age group. And it's also on the back of this paper that we were able to estimate that annually in Malaysia, we're probably going to get about 5,500 hip fractures annually. And this reading becomes a bit more grim when we look at this piece of work that the Asian Federation of Osteoporosis Society put together and published a few years ago. And Malaysia came up top in this particular leaderboard, which tried to project the increase in the number of hip fractures by the year 2050. And driven by Malaysia's aging population, our country is going to see a 3.5-fold increase. So that's a 350% increase in the absolute number of hip fractures from now until 2050. So if we're talking about 5,500 estimated hip fractures annually at the moment, this report projects that by 3 decades from now, we'll be looking after just under 21,000 hip fractures annually. And hip fractures are pretty expensive, and the projected direct healthcare costs of treating 21,000 hip fractures annually comes to about 520 million ringgit annually. And this is just in direct healthcare costs. But we've looked at the population level so far, but from an individual level, we know that sustaining one osteoporotic fracture increases the risk of another osteoporotic fracture. And depending on the recency of the fracture and the site of the fracture, this risk is somewhere between 2 to 20 times. But the worrying thing is that each subsequent fracture has a greater impact in terms of adverse outcomes and morbidity onto the individual than the fracture preceding it. But this risk of another fracture isn't exactly constant over time. Most of the increased fracture risk is very much concentrated within the first 18 months after a fracture. So what this means is, if let's say someone sustains a fragility fracture and they're going to get another fracture, chances are it's going to happen 18 months after the index fracture. And when you think of it that way, it very much changes the way we should view secondary fracture prevention. That there is now an urgency to ensuring that we try and prevent the next fracture as soon as the first fracture has occurred. Now, how do we do that? And it's not rocket science, really. To prevent another fracture very much requires us to focus on two simple things. The first is to treat the bone fragility. So, making sure osteoporosis is diagnosed, we identify secondary causes of low bone mineral density, those that need treatment are started on treatment, and those that have been started on treatment continue taking the treatment. Secondly, it's about minimizing falls, because falls contribute about 90% of all fragility fractures, and falls are usually multifactorial and which requires an individualized and targeted intervention. So someone who sustains a fragility fracture, and if we did neither of these two things, it is very, very likely that that individual is going to sustain another fracture. So, with regards to, say, how are we as a hospital, as an institution are doing, I thought I'll share with you just two performance indicators. The first one being DEXA scanning. Okay, so DEXA being a means of assessing bone mineral density, It's the gold standard to diagnose and monitor osteoporosis. So we looked at an inpatient cohort. So these are patients who had to come into hospital to be treated as an inpatient for their fragility fracture. Excluded some numbers, excluded some patients, and out of a cohort of 226 patients within the year of 2018, just about 34% had a DEXA planned, a little bit less had it requested, and where it was requested, only 2/3 of patients turned up for their DEXA assessment. And we think of fracture prevention as a time urgency thing. From fracture presentation to the request of the DEXA, we've got about 30-day median time from that taking place. From it being requested to it being performed, there was about a 40-day median time wait. So all in all, an individual so far who's had a fracture, who's come to hospital to be treated, would wait just over 2 months before a DEXA would be performed. And this is before we factor any other intervention that needs to be put in place after the DEXA has been done. Second performance indicator, initiation of anti-osteoporosis medication. Again, similar cohort 2018, inpatients, excluded some numbers, and we had a cohort of 227 to look at. Only 26% were started on anti-osteoporosis medication after their fragility fracture. And the reading becomes a bit more depressing when we went back and see whether they were still taking the medication 12 months later. And that drops by about half. So all in all, we don't seem to be doing particularly well, and what we call this to be a big treatment gap. So is there a solution to this treatment gap? And the answer is what you can see on the screen. It's something called a fracture liaison service. So a fracture liaison service is a coordinated approach where it's led by an individual or a team of individuals who will proactively and systemically look for individuals, look for patients in different settings who've had a fragility fracture. These patients are then referred on, passed on to have risk assessment, whether that be of their bone health or of their false risk, plugged into the relevant services so that treatment can be initiated. And part of the FLS work is to ensure that any treatment initiated, whether that be osteoporosis medication or whether that's a false intervention program, continues during the duration when risk is particularly high. So we've started doing some of this within PPUM, and we'll go into that in a little bit more detail when we discuss the service. But what we're really, really proud of what we've achieved so far in a very short space of time is some level of recognition from the International Osteoporosis Foundation. So what this is we've got a star, which recognizes the work that we've been doing in improving fragility, fracture, secondary prevention. We've got a bronze star. The aim is to eventually get to a gold star. And that's certainly a work in progress. So I'm going to perhaps just stop here for the time being. I'm going to exit my screen and I'm going to invite my 3 esteemed colleagues here who will also be able to provide some insight into how we are doing and what some of the challenges we face are. So perhaps I'm going to direct the first question to Dr. Kumar, really. So Dr. Kumar works in orthopedics. Morning, Kumar.
Good morning.
So I guess the question I've got for you is, why do you think there is this gap in secondary fracture prevention, certainly within our clinical practice?
Okay. If I want to start it off, I would just say, let's put it as hip fracture or geriatric hip fractures or fragility fractures, whatever that we may call it. It is not as popular as COVID. It is not as popular as dengue. Even in KKM, we have a CPG which is actually done for snake bite prevention. Let's see the incidence of that happening or that we know of, but we don't have a CPG for managing hip fractures. But anyway, it has been started quite recently. It is still in a very infantile stage. And one of the main concerns for me, as far as I'm concerned, that when I see patients and who have been managed, and orthopedic surgeons, orthopedic MOs, this is across the country, the first thing that we want to do is fix the fracture, discharge them, and let them go home, and just go home and pray they don't come back with another fracture. So it doesn't seem to be very helpful as far as the prayers are concerned. because they are not putting any additional effort in doing something very simple, what I call a referral to the concerned people on managing this secondary prevention. Even though they don't have to do directly, all they need to do is a referral thing. That is seems to be lacking very much. As far as the university hospital is concerned, we have batches of medical officers, master students who come in and leave and all that. And it has been a repetition again and again and again. But generally, it just, if you take orthopedics, we have many subspecialty units. And the orthopedic trauma unit is the one managing this. But nevertheless, the other units also have fractures related to fragility. And they themselves may not be aware that there is a person that they can actually refer to prevent the secondary fractures from happening. So lack of knowledge, lack of awareness is the key important thing that says that there is a big gap in preventing this. So I think the first thing that we need to do is educate the doctors who are actually managing this. So that is my take on this, that the doctors, the hospitals, various hospitals and doctors who are managing the geriatric fractures should be taught first on how to go about preventing the secondary fractures.
Thank you, Kumar. And I think if anyone wants to chip in with a question or a comment, please feel free to use the Q&A chat function. But I think Dr. Kumar's nicely highlighted some of the systemic issues that we have with addressing secondary fracture prevention effectively, which is why a solution, as I've alluded to, is this FLS service. And perhaps I can now ask Dr. Khor, you want to expand a little bit about the UMHC FLS service, what we've been doing, how long we've been doing it for, and perhaps some of the achievements that we've been able to demonstrate in this short period of time.
Yeah, thank you very much, Terence. So I think back when I first came back to UMMC, and in 2016, we started off venturing into looking after inpatients together with our orthopedic colleagues, because a lot of elderly women or men with hip fracture have very poor prognosis. And on top of thinking about what to do with their bones thereafter, we are even just struggling to get them stable enough to go for surgery, and even post-surgery for them to be stable enough to be discharged. So obviously, along that way, we find that, yes, we're looking after them, but at the same time, they have a lot of other factors that needs to be sorted out. So sometimes in terms of osteoporosis management, secondary prevention may have left to be dealt with in the outpatient. So we see that there is a huge gap. Besides looking after inpatient, we have to think about what happens to their bone thereafter. So the fracture liaison service helps to bridge this gap of secondary prevention. And after a couple of years now, with parents coming back, we need to expand the service. We can't just look at hip fractures per se. We need to look at other fractures that come to hospital that requires secondary prevention and also their bone health assessment. So in the last about 1 to 2 years, we have this, what we call now the fracture liaison service. And we have a very hardworking FLS coordinator, Min Hui, who have been, working very hard to capture all these patients who comes in and get their bone health assessed, and also to initiate treatment. So she calls them up, after about 3 months, 6 months, to ensure these patients are still on treatment and to ensure that, their bone health has been assessed properly. So I think how we're doing, there are improvements, although I would like to admit as well, there's a lot more things that needs to be done. And now with what Dr. Kumar has mentioned about, the MOH likely coming out with the geriatric hip fracture guidelines, I think that would also help to increase the uptake of FLS services in a lot of other hospitals as well.
Thank you. Thanks, Dr. Khor. I was just going to bring Dr. Jaya into the discussion here. So we've talked about the gap. We've talked about how we've seen some improvements in terms of our secondary fracture prevention in PPUM since we've had Min Hui that Hui Min alluded to just now, improving some of these figures. But if we look at it from a more from a bigger picture, do FLSs really work? Can it really reduce the risk of another fracture? And perhaps one that some stakeholders might be interested in, does it actually save money? Is it cost effective doing all this?
Hi, good morning, Terence. And before I start, I want to congratulate you on you and Hui Min and as well as Kumar on initiating and running the whole FLS service in UMMC. And it really does close the gap on osteoporotic fractures. In terms of benefits, I think if you look at bigger studies done around the world from the US, you have I think classically people would quote the Kaiser Permanente cohort in Southern California, the Gynaecology cohort in the US, as well as some of the British cohorts where you have been at the UK, would tell you that definitely that there is a lot of benefits with fracture liaison service. I mean, in terms of, you just mentioned just now, in terms of fractures fracture begets fracture. So it has been shown that with FLS implementation, you can reduce the risk of hip fractures by about 40%. And mind you, that is better, almost better, if not equal to some of the anti-osteoporotic treatments that we have today. Of course, as you correctly pointed out, in terms of cost savings, there have been calculations that have been done, and that actually amounts to the millions. You do know that, and you did highlight just now, that hip fractures do amount into a lot of costs in the millions in terms of healthcare costs. So the FLS definitely can bring down the cost, and that's been shown and that's been published before.
Thank you, Jaya. So I think certainly the evidence base for fracture liaison service has been fairly consistent in that it does work. It can potentially offer cost savings, and not that I want to compete with our living dearest and nearest neighbor, Singapore, but they have certainly been very successful in implementing a national fracture liaison service, and they've certainly reaped the benefits with regards to effective secondary fracture prevention. Now, I've seen some questions in our Q&A and in our chat, so perhaps I can throw perhaps the first one from Prof. Tan to maybe Hui Min, if you want to take this. Prof. Tan made a comment, says, I would like to see falls prevention merged with fragility fractures prevention. And I presume since it is the best form of prevention, what do you think?
Thank you very much for the question. I totally agree. So basically what we see in a lot of countries overseas, currently the treatment for fragility fracture is merged with falls as well. Hence, a lot of time, even when in the UK, when they come up with guidelines, is now called falls and fragility fracture. So I do see that this is very important, and I think there is a lot more we can do for our elderly patients who have had a fracture. You know, we've got a falls team in Universiti Malaya hospital, so I think there's definitely a lot of work that can be done to collaborate together, so to ensure that these patients not only have their bones fixed, and not only that they are safe enough to go home, but also have had a falls prevention assessment, a thoroughly done falls prevention assessment to ensure that it reduces their risk of getting another fracture again.
Yeah, and I certainly echo what Dr. Khor has said. No point giving them tablets if we don't stop them or try to stop them falling over, which I mentioned in my presentation. 90% of all fractures are due to a fall. So falls prevention becomes really, really important. And I have to credit Prof. Tan and the geriatric medicine team for certainly an excellent fall service that we provide in PPUM. So I expect a flood of referrals to go into your fall service now, Prof. Tan and Dr. Khor. Okay, there's a question here from Prof. Tengkusara. So well done, thank you very much. But can we have a fracture prevention liaison group? So Jaya, shall I throw that in your direction?
Yeah, I think it's very pertinent, Prof. Tengkusara. Thanks for that comment. Obviously, fracture prevention is also something that you want to focus on. But as Terence has showed us clearly, and we know that even those who have got fractures are not being treated well enough. And these are the high-risk individuals. We are only actually sort of like handling the tip of the iceberg here. And if we're not even doing that properly, actually, I mean, to be honest, because as he has shown us, only about 20-30% of patients actually get a DEXA scan, only about 30% are initiated on anti-osteoporotic treatment, and maybe only about 20% or 30% then on actually persist on treatment. So there's a big gap there, which we're trying to handle in terms of secondary prevention. So I think that's going to be our focus and priority, and I think we'll have to prioritize that ahead of fracture prevention for now.
Thanks, Jay. I completely agree. I think preventing the first fracture is perhaps the best treatment to treat fragility fractures, stopping them breaking the bones in the first place. And I think certainly that would be the aspiration. But for now, we've got this big cohort of people who already have broken the bone, and we need to try and stop, making the first fracture the last fracture they will ever get. And I want to thank the audience for your very encouraging comments, certainly from Yu Kuen Chan and again from Kung Ku, because your point about it's not only money-wise, it's not about the direct healthcare cost, but there is a huge personal cost to sustaining a fragility fracture. And if you think about hip fractures, which we've alluded to so far, it's the worst kind of osteoporotic fracture that you can have. At least 60% of those with a hip fracture do not return to their pre-fracture level of function. So it's a very disabling injury, and if you can prevent it from happening, I think that would be a really big plus from many different aspects. So there's a question here, and we'll probably make this the last question for this particular session, which asks, what are the major gaps in terms of osteoporosis treatment currently in Malaysia? I don't know, Kumar, shall I throw this in your direction? What do you think?
Yes. As far as this osteoporosis treatment, we're talking about major gaps. Now, before that, I would just like to highlight on the part that one of the things that Prof. Sarah has actually mentioned. There are, how we came about enforcing usage of masks for prevention of COVID. We can actually sort of use this technique to enforce something like just a form to be filled up by every specialist concerned, that if you're going to buy an implant for the patient, the referral form needs to be filled up first. That's a fantastic idea here by Prof. Sarah. So that will actually make way for this to have market improvement among, while having no choice in order to have this surgery going on, they have to sign the form and needs to be referred. Another thing is that I would like to highlight what again Prof. Sarah has actually mentioned. Again, back to, taking it as an example from COVID itself, all of us know, without fail, all of us know that how the vaccine producers are actually making money out of the COVID vaccine. So just like that, out of this fractures, the implant companies are laughing their way to the bank. So I feel that they should give back something in return. At least from on our government side, a separate funding should be allocated just to support the implants, where elderly patients, sometimes they have to rely, either they are staying alone, we have to rely on social workers and things like that. I think this implant should come to a stage where it should be made free for these patients. So these are some of the gaps that I think, you see, we haven't even started with this. And then in managing the osteoporosis gap, this is the way to go. We enforce it, make it like, bring it literally like a law. Having a law is one thing, and enforcing it for good. And it should imprint on people's mind forever. So this is the way to go. Make it a law.
Thank you, Dr. Kumar. So yeah, I think what Kumar is saying is that the gaps are across the board, from a funding perspective, from the way we deliver the service. It's just a whole parcel of gaps that we do need to try and address, perhaps one at a time. Dr. Kumar drew parallel with COVID masks. I'm not sure if instilling a 3,000 ringgit fine if you don't send someone for a DEXA scan would go down well. It would generate revenue and sustain our service, but we'll have to ponder on that. I'm conscious of time, and I'm glad that so many of you stayed on till 9 a.m. to listen to us briefly talk about this. There are some more questions and comments that I didn't get a chance to go through, but you've now got names to faces to people behind trying to push this agenda forward. Feel free to get in touch if you'd like to engage us further. We're more than happy to do that. So with that, I just want to thank all of you for tuning in to today's episode of Breakfast at UM. On behalf of the organizers, we hope to see you at the next edition, the next episode of Breakfast at UM. So thank you very much. Good day.